so that when we take a step back and we move on to another project, that people locally, governments, NGOs, organizations in the field, that they can continue to work on the program that we have installed and that we have implemented. And so that is what we do. We have a couple of focus areas. We have tuberculosis as a focus area. We have mental health as a focus area, mental health being one of the primary death causes in the world, as noted by WHO just a year or two ago. And of course we have HIV also as a focus area, and given that that is a focus area, that is one of the reasons why we are here today. So in a nutshell, global public health, it's not about selling medication, it's about impact on people's life in a sustainable way, setting up programs locally. That said, the dengue hackathon was very successful in its entirety, and that is basically the cause why we are back here today and with an attempt of doing another one, hopefully as successful. Voilà. This map shows you the surface of the world, but modeled by HIV prevalence. HIV prevalence being the number of people living with HIV in a particular country divided by the population. So it's not needed to say that if you look at the African continent, that the surfaces are very, very large, which means that basically in Africa, in sub-Saharan Africa, quite a lot of people are living with HIV. As a matter of fact, today there are roughly 38 million people worldwide living with HIV, of which roughly 26 million live in Africa. So that's quite a lot. Out of those 26, 17 million are being diagnosed. That means that out of those 26 million, 17 million people know that they are infected. That is 9 million don't know that they are infected. And out of the 25, 13 or roughly 14 million are getting treatment. So that's about half. So there's still a lot of work to do in the world out there. Where do I point? Now the good news is we're already that far that roughly 14 million people are on treatment. And if you look at this graph, the green people are the ones that are on treatment, and as you can see over the years that has increased. So this is really good. The world organizations such as UNAIDS, WHO, pharma companies, other organizations are paying a lot of attention to this, and more people are on treatment. However, this comes with an additional problem, and that is that drug resistance, so that the virus is resistant to your medication, that risk is looming around the corner, and I'll tell you why in these next few slides. So in the beginning, as you are infected, your viral load, the amount of virus in your body, is high, and you get what is called a first-line medication. So the first time you're on treatment, that's first-line medication, and if that works well, your viral load is being reduced. The virus cannot replicate anymore that well, and so your viral load is suppressed, even to the extent that it can become undetectable. Note that the current medications that exist do not cure you. It just suppresses the viral load. So the virus is still in your body. Now, one of the caveats with HIV medication is that you have to be compliant to your treatment. That basically means that you have to take your medication every day as prescribed. Because if you don't do that, then you allow the virus to replicate again. And so the HIV virus is notorious for replicating very fast and for making a lot of errors in its replication process. And these errors are called mutations. And so if you don't take your medication, you allow the virus to replicate. It creates these mutations, and and you basically give the mutations the opportunity to be resistant against your medication, because it creates errors, copies, different strains of the virus that can, where the medication is not well suited for. And so that is why, even though we're getting better at the treatment of people, more and more people receive treatment, the risk of not being adherent to your treatment is becoming bigger and bigger, and therefore the problem of resistance is becoming bigger and bigger. We all know from when we were young, or we are still young, that when we had to take antibiotics, that the doctor said, or mom or dad said, you have to take it to the very last pill in the box, because otherwise it's not going to work. It's more or less the same mechanism here. That being said, if then your first line treatment is not working anymore, then you need to switch to second line treatment, to another therapy. And for the countries that we operate in, well, the first graph that I showed was where the problem of HIV prevalence, the number of people living with HIV is very prevalent here in sub-Saharan Africa. But these are also the poorest countries. That's the surface of the world according to the economy. Right? So that means basically that the problem with the second line medication is that it is much more costly than the first line medication. And that when you need to switch therapy, if your therapy fails, you basically need to do additional viral load testing. You need to do resistance testing. And these things cost a lot of money. So if you combine these three factors together, the fact that, say in sub-Saharan Africa, there's a high prevalence of HIV, these are poor countries, and if you need to switch to second line therapy, plus these additional testing, which is way too costly, well, these countries have all the interest to keep their patients as much as possibly can on first line treatment. And that is where we as Global Public Health want to have an impact. We want to know where we can take preventive measures, where can we educate people, where can we educate governments on what to do. So we want to identify where these pockets are, where HIV drug resistance is emerging. On the one hand, so that we can go there and work with these people. But also in doing so, we want to identify which factors contribute to the problem. And not only epidemiological parameters or disease parameters, also other factors like education, like healthcare infrastructure, like the amount of money that a country spends on healthcare, right? And if we can find these correlating factors, then we can turn these correlating factors hopefully into some actionable items. If we find out that people are not well educated on HIV, for example, and that we can set up programs which help educate them, that's turning the knowledge that we gain out of an exercise, out of a data science exercise, that is how we turn this knowledge into value for the countries, into potential actionable items. We're already busy quite a while on this program and project, and the hackathon as such is an additional component. Why are we doing that? Basically, as a company, as an organization, you have a tendency to look into one particular direction for a solution on your problem. And the dengue hack and the experience we had there and the experience that we have today with something like a hackathon, it's actually a very innovative approach to open up your horizon, to open up your mind, to allow other talent, other professions, look at a problem which is not directly theirs. And it's precisely that that is very innovative and can learn and bring new insights to you. And that's why we do this. So we've done already some literature study. We've talked to experts, and Jenny is going to talk more about that. I have to make sure that I don't take the scoop of her presentation. But basically, there are a few variables that we have already discovered beyond the disease, beyond, you know, that have an impact or might have an impact on the emergence of drug resistance. So what do we do with this? As already explained a couple of times, we inform the country on the level of resistance and in their potential level of resistance in their country, on patterns, on trends. We basically want to help train the healthcare workers so that they can better explain to their patients why it's so key and critical to take the medication and stay and be adherent and compliant to your medication. Knowing what the problem is, you can also inform other organizations. PEPFAR, for example, is an organization out there in the world that funds a lot of medication to countries. So you can inform them on the need for second-line medication, third-line medication, on the need for budget, basically. And also donors and suppliers. Bill and Melinda Gates Foundation is a very well-known donor of medication. Suppliers like ourselves, getting a perspective of the need for the medication, in this case, second line and third line. Oh, one more. Yeah. So basically, that's why we do this hackathon. That's why we call upon you, and it's fantastic to see so many people in the room today. And I have 2 other slides. So why do we call upon you? Well, basically, we can't do it all ourselves, and there is a lot of data out there, but we need to kind of gather it and try to collect it, and bring it together in a fashion that it can be used in an exercise like a hackathon. That's one element. Second element is basically come up with new IDs. I put here drug stock outages as an ID. Why is that? Well, in our world, if you go to your pharmacist and the medication is not available, you go around the corner to another pharmacist and you pick it up there. In the countries that we talk about, it's about 50 kilometers walking on very difficult roads to the pharmacy. And so if people come there, their medication is not available, they go back home, they lose a day, and you don't see them for another 6 weeks before they have picked up from somebody else that the medication is available again in the pharmacy. Now, if you marry that together with the fact that for your HIV medication you need to be compliant, the fact that your medication is not available in the pharmacy, you involuntarily become incompliant with your medication. So here you have a nice example of an influencing factor that has nothing to do as such with the disease, drug stock outages, but still has an influence on the treatment of people. And we have put up a few use cases. These are just a few examples. We have put up a few use cases basically to give you some guidance where to look, what to look for. And another one was guidelines and text analytics. Why is that? Because a lot of information is being published in reports and documents, and so quite a lot of information is unstructured available in these reports. And as digitizer, here the Data Innovation Hub that it was previously called, you're technologists, you apply tools, and so that was an ideal case to learn about a new tool, a new technique, and try to extract information that could be of use in the context of what I just spoke about to help solve the problem. So that said, basically the hackathon, the dengue one and also this one, for us as an organization is very helpful because it helps us discover new organizations and new tools that might be of use in solving a problem. As a matter of fact, from the dengue hackathon, we went on with 2 companies that we got to learn there. We discovered there, and we now have a full-fledged project and contract with them to actually really solve the problem. So that was a value add to us as an organization. Data, there's, what is it, 50 people in the room. That's much more than just these 2 hands or these 6 hands that can search on the web for data. So that is a leveraging opportunity. And then talent and IDs. Well, I'm looking at the room here, and I see a lot of bright young talent that can help us in trying to tackle this problem. So that's why we are here. So that is, I hope I was able to explain why HIV drug resistance might become a problem or is becoming a problem, because already some companies, some countries see 10% observe 10% resistance, which is quite a lot. And so why, as a company, as Johnson & Johnson Global Public Health, we engage in a hackathon like this and apply for your talent in trying to solve the problem. So that's my story, Philip, or our story. So
basically it's all about hands-on, right? So you are here to learn by doing, and that's that's what we want to do, and it's going to be enriching for everybody, because on one side you will learn, but you will probably ask the necessary question that will make people think that maybe that kind of data could be useful as well. So your questions as newbies in the area will probably feed the people from research at Johnson & Johnson as much as they will feed you with information on drug resistance. So don't be afraid to ask questions. Don't be afraid to challenge. Don't be afraid to say, oh, why don't we just use that kind of database? Because maybe just that kind of database could be the one that would be useful. I remember from the dengue hack that Anna used Twitter data, for example, to identify where will be the next hotspot of dengue. And she managed to do it as well, which is, she had the idea, she brought people together, like you might have an idea tonight, and bring people together and work it out. Was her solution perfect? That was not the point. The point was, that's a good idea to look more into depth and to continue working. Now, concerning Anna, what she did, during the hackathon, she learned about machine learning. She got motivated by what machine learning could bring. She went into deep learning, and then she went to MIT, and now she is in Boston. Why? Because we just, she signed up for a hackathon, being a postdoc graduate and not really knowing what she wanted to do, found out that there was something to be done, got motivated, focused on the topic, found an opportunity to go abroad, and yeah, she'll be coming back. So that's the good news for us, but that's quite important.
Yeah, thank you, Philip. I do want to reiterate and stress the fact that it's not about the perfect solution. It's really about the experience. For you, for us, it's about the challenge. It's about getting to learn people, organizations, tools that can contribute. And that is the value that comes out of the hackathon, less so the specific solution. There were, as Philip pointed out, there were other ideas that came up which were really unknown to us. A game on trying to educate people. Minecraft, most of you have heard about Minecraft. Well, during that hackathon we learned that there was a version of Minecraft specifically aimed at educating people how to deal with these mosquitoes that carry dengue and then that infect people. So it's all about that, the experience, not about the perfect solution. So just bear that in mind when you're getting frustrated on trying to on your hands-on experience.
Good. Well, next speaker is so the next speaker will be Jenny. Jenny has been compiling data for the past year, data together and trying to understand the sense of all that data. While her presentation is loading, I will hand over the mic. So, Jenny, thank you for being here.
Yeah. Thank you, Philip. So, as Serge has mentioned and Philip has mentioned, I have been working on HIV drug resistance for a while, so I will share my experience and challenges that I have encountered from finding data around HIV drug resistance till a global HIV drug resistance data set. So I will first tell you about the issue that we had in the first case and why we actually do this project. And then we built a list of HIV drug resistance influence factors. And based on this list, we would like to find some data on it in public locations. And by doing this process, we have encountered challenges that I will share with you. And at the last, we will have a look at the global HIV drug resistant dataset. The issue, or actually the motivation that we had to begin with this project is that this map. This is a map representing the data of transmitted HIV drug resistance in the year 2008. So the red colored countries are the countries that have this HIV drug resistant data. However, we would like to actually color these other countries. They are in gray. And these data are extracted from the Stanford University HIV drug resistant database and is limited to certain countries and limited to till the year 2012. So what we like to do is first to have HIV drug resistant data on the gray countries and also beyond the year 2012. And that was our goal for this project. How do we do it? First, we built a list of HIV drug resistant influence factors, and we have 3 methods to do it, or maybe more, if you can think of it. First, we looked at the literature. We searched in the scientific manuscript where are the significant factors that are related to the developing or observing HIV drug resistance. And we also talked with experts in the field of AIDS or HIV to find out their experience and their knowledge on the field, whether there are other influence factors that we missed in the literature. And also by talking with each other or other people in the other fields, like in economics, we can maybe come up with other factors that can contribute to HIV drug resistance. By doing so, we come up with this list of potential influence factors and their proxies and surrogates for the outcome data per country and over time. We have country-related variables such as life expectancy, gross domestic product, and population. We have HIV-related variables such as HIV prevalence, incidence, ART coverage. ART stands for antiretrovirus treatment. And in the healthcare system, we have also influence factors such as how well a hospital performs and how many nurses or doctors are in there in a hospital. From resistance studies, we can find out indicator of, that can contribute to the HIV drug resistance. For instance, from HIV, from the WHO and the national surveys. And WHO has also early warning indicators that's actually saying about the HIV drug resistance status of a country. And also from forecast studies, we can learn from it to see what kind of factors that is contributed to the ARV. And ARV stands for antiretroviral medicine, or the viral testing. And also what else are there? And maybe you could fill in this list. So by building this list of HIV drug resistance influence factors throughout literature, talking with experts and discussion, we have this list. So the next step is we look for data of these influence factors. Are there data publicly available? And actually, yes, there are data publicly available. We found actually data from each of the influence factor, not all the influence factor, but most of them. So the data can vary from size, and also the units of the data varies as well. Some are in percentages, some are in the numbers. And let's go to these data that we found. We have data that are related to HIV and data that are not related to HIV. Among them, there are life expectancy and death variables, rural population, literacy, education expenditure, and finance, staff in the health sector and the health infrastructure, and the health expenditure and the educational variables. Within the HIV-related variables, we could find the HIV prevalence and incidence, ART coverage, and HIV drug resistance in these sites, such as UNAIDS, UNAID, WHO, the Stanford University HIV drug resistance database, and the United Nations. And for the life expectancy and death, we have these 4 variables that we can find on the website of the World Bank and the WHO. And on the same website, we found variables related to rural populations, literacy, education expenditure, and finance, and more actually, about the health staff and about the health infrastructure, how many hospitals a country has, how many physicians that a country has, and more actually, the expenditure. And here you can see that there are different kinds of health expenditure, the publicly health expenditure, the private health expenditure, and out-of-pocket expenditure, and more. So there are a lot of data out there. And via literature study, we can find even more about the education variables and how many people have attended their school at different kind of school level, like the primary school, secondary, and the tertiary level, and how many people are completed their school. So by looking on the internet and gathering all this data that is coming from public locations, we have put in data sets together, and during this process we have encountered different kind of challenges. Challenges in the data quality, in the validity of the data, and also the amount of missing data, and the correlates that in the data. So for each of the challenges, I will give an example. For the data quality, the example is we have found estimates of HIV prevalence on the website of WHO. the first question they were asked is, how are these estimates calculated? Then we trace back to the source, and we found out that these estimates are coming from the Demographic and Health Survey report. The second question is, how can we rely on these reports? Where do the raw data coming from? So for looking further, we found out that the raw data are coming from the DHS survey. And by looking at the survey, we can ensure that the data are correctly collected and the estimates are correctly calculated. So by tracing back, we can ensure the quality of the data. So we can go on further to looking at the content of the data. An example here is example from the rural population. Yeah, the table is quite small, so yeah. The second column is the rural population of Belgium from the year 1978 until 2015. And the third column is the rural population of Hong Kong. And if we compare them, in 1993, Hong Kong has 0 rural population percentage until 2015. So we can wonder, is this data correct? What I have done is look at the definition of rural population in the World Bank, where the data is coming from, and see whether the content is actually correct what I have seen in the data. So the definition said that rural population refers to people living in a rural area as defined by national statistic offices, and it's calculated as a difference between total population and urban population. So, and also the countries have different ways to define rural population and urban population. Some country will use the presence of certain infrastructure and services to define urban areas, and the other country will use administration arrangement. So by looking at these definitions, we can say that the difference between these two countries, Belgium and Hong Kong, is okay. And also the 0% are actually correct. So by looking at the tracing back at the source, we can say the content of the data are correct to use for the next step. So we have checked the quality, and we have checked the content of the data, and we have put in together a data set. Then we have done missing data screening. And here is the result on the right side. The x-axis is the variables, and there are 66 variables in it. And here is the country values for a certain year. The redder the plot, the higher the amount of missing data. The lower the plot, the whiter, the lower the amount of missing data. So this plot shows that a lot of missing data. But however, this plot shows an indication that some variables are correlated with each other. And I have to tell you that we have challenges in the data quality, data validity, and missing data and correlates. So why don't we look at the data itself and see what this data tell us more? So here is a screenshot of the global HIV drug resistant dataset. The columns are the variables here, and the row are the value for the country and for a specific year. And the variables, has also, here I have the description of the variables. There are in total 66 variables. Here something about the country and also their ISO 2, ISO 3 codes. And here's a bunch of HIV-related variables. And the second column represents the description. And the third column is the percentage or the number actually saying the units of these variables. And these variables are actually available for you for the hackathon to have a hands-on session with it later on. And what I can tell is some of the variables has a lower bound and upper bound. And these are also included. Except the HIV-related variables, there are educational-related variables, health-related variables, and the most important here, the four last one, are the HIV drug resistance variables in it. So, in summary, we have identified what the issue was for this project. And we have built a list of HIV drug resistance influence factors. We have searched for data. They are available publicly. They are available in a public location. And we have put together a data set. And we have shared some experience and challenges that we have encountered. And we have showed you a glimpse of these global HIV drug resistant data sets. And our question is to you, would you like to find out more about this global HIV drug-resistant dataset with us from your own perspective? Or in other words, would you like to be the next Miss Marvel of Sherlock Holmes? So the data, you can find it in the Google Drive, in this link. And the dataset is named here, and the metadata with the description of the parameters is in these Excel sheets. So, thank you very much. Yeah, maybe this one. For the hands-on session, we'll be working around, and you can ask us any question as you want. And after today, you can also contact us on this email address for further question about the dataset or other kind of things.
Thank you very much, Jenny. Concerning the contact as well, there is that forum on HIVHack.org, and of course some of the questions can be answered by the group, and it's also worth it to put a question on the forum to make people think and make people try to find an answer as well, and you learn a lot by putting those questions on the forum. We will review the questions on the forum, and when we see that a question is not answered fast enough, then we will refer it to Jenny and to the experts. But I would really like you to share your questions among yourself first and try to find an answer by talking to each other. And that's the objectives of our evenings here. So is to allow you to meet each other, change email addresses and so on, so that you can ask questions. So don't underestimate the work done by Jenny. It's been a long way, and it's already amazing what she has achieved. For us who have our nose on the data, we feel like there is still not enough, and that's the call of Jenny. Basically, is that you and if you have more data, if you have more ideas, just bring them in. The richer we can make that database, the better the outcome would be. Yeah. So there is some good news that we have a database. It's not rich enough, but there is work for you to enrich it. We still have one presentation from Serge waiting, and the food has arrived. So that's probably, so I would suggest, Serge, if you agree, that we move on to the pizzas, and then in about 20 minutes we come back and then listen to Serge's presentation, and then you can start forming a group and discuss the data set that Jenny has created and be in constant interaction with her, because the work she has done is very thorough. So, bon appétit, and see you in 20 minutes.